All right, welcome back to House Healthcare. It is still Wednesday, January 10th. And we are really shifting gears now, and we're going to talk about insurance claims processing. So what we're going to do this morning is really educate ourselves on claims processing. Not all of it, because that would take us about a year, but we're going to focus in on a couple areas. We have providers who are going to walk us through how it's done, what they have to do, and then what has occurred since about April, May of last year when some of the insurance companies made some changes, and then the effects that it's having on our providers. So it is really education. I encourage everyone to ask questions. I am going to continue to have you raise your hands, and I might say, write it down, we'll come back to it because I want to make sure that we get through everyone. And so education, and then this afternoon will be the same topic, and we'll have Department of Financial Regulation and Blue Cross Blue Shield, and MVP has sent written testimony, which may make sense now, or may make more sense at the end of our session today. So this is the first step, and then we do have a bill that's being introduced, so we will come back to this once that's introduced to figure out if there's anything we need to do. So, any questions before we start? And for witnesses, we have one representative on Zoom, so she'll raise her hand if she has questions, and I'll make sure I include you in the rotation, Mari. And for some reason I don't see it, just text me. So we're going to start with Julie Lynn, who's an independent dermatologist. Come on up. Good morning, Julie. Thanks for being here.
Just gonna set a timer to make sure I don't go over time.
Oh, that's fine. I appreciate that.
Are there any introductions that are necessary?
So actually, that's a really good idea. Why don't we introduce ourselves, since we have a full group, and some people haven't been in here before, and then we'll turn the testimony over to you. So Art, do you want to start?
Yes, Representative Hopkins, I represent Rutland District 2, Clarendon, Wallingford, West Rutland, Rutland Town.
Leslie Goldman, Wyndham 3, Bells Falls area, Rockingham, Westminster, and Brookline.
Daisy Rebecca Winooski.
Mari, you want to go?
Mari Cordes, Bristol, Lincoln, Monkston, and Starksboro.
And Topper McFawn is not here today. I'm Lori Houghton. I represent Essex Junction.
I'm Melissa Black. I represent Northern Essex.
Alan DeMar representing Enosburg and Montgomery.
Melanie Carpenter, I'm from Memorial 2. I represent Johnson, Belvedere, High Park.
And I'm Bobby Barnes Rubio, and I represent Barnet, Reigate, and Waterford.
Great. So we can introduce yourself for the record, and then do you want us to wait till the end of your testimony for questions?
I don't care.
Okay, so we'll manage that, and then we'll figure it out.
I'm a little bit of a fast speaker, so just please stop me if
Okay.
you're not understanding.
Okay.
So my name is Julie Lynn, and I am a physician and a community independent dermatologist in St. Albans. I was prior an academic dermatologist at UVM for about 10 years, starting in 2009, and I'm now in my 5th year as an independent community practice in St. Albans and Franklin County. So I've kind of seen the world of employed, you get your paycheck no matter what, versus now very close to the bank. So, as I'm also a member of Health First, one of the former board chairs, also a member of Vermont Medical Society, VMS board member. Okay, so as a dermatologist in St. Albans, we're the only dermatology practice north of Chittenden County, and we're a very small practice of 2 doctors. And we provide care to a very large geographic area. It's an underserved population for our specialty, and it's not unusual for patients to travel hours to see us from out of state and even Canada. So Northern New York, Northeast Kingdom. I had someone drive up from Rutland this year because they couldn't get an appointment locally. So that's how in need our specialty is, and especially in Franklin County. And prior to us being open in 2019, there was no dermatologist up there. People had to drive to Chittenden County, or they just didn't get care. At one point, UVM had a clinic, 1 half day a month, but that had not been in existence for a long time. So if our office doesn't survive because of the administrative burden of running a small practice, the patients that we serve right now, they're either going to travel to Chittenden County or they're just not going to get care. And the wait time for our specialty already averages 4 to 5 months for any dermatology practice in the whole state, not just ours. Okay, so I'm really here to discuss the administrative burden of insurance billing and the impact it has on patient care. And this also contributes to physician-provider burnout in a state where there's already a shortage of providers. And the reason is right now, there's no one standard way to get paid. So each insurer has its own processes and policies, and each year it gets more onerous. And you have to keep track of all the changes and abide by the new rules. It's not like a standard, you know how to go to ATM, you put in your card, you put your PIN, you get the money out. It's like for A, you do this, for B, you do this, C, this, if not. So it's very hard to keep up with everything.
So I'm sorry, I just want to be clear. So when you say insurance, we're talking about every insurance company that someone might have. So it's not just Blue Cross Blue Shield and MVP in Vermont. It could be Cigna or United or whoever. They all may have a different process.
Yes, and we accept all major insurance carriers, Vermont Medicaid, Medicare, and all the private insurers, whoever we are allowed to be credentialed with, we have credentialed. So it's been a national trend for insurance companies to implement additional software to automatically perform claims edits, and I'll go through kind of what that is. So claims editing, it's a process of reviewing claims, and I'll explain what it is, for coding the validity and accuracy. And the claims are typically processed through a computer algorithm that automatically flags claims with specific codes or modifiers. These are letters or numbers for review. And they may either lower payment or they'll withhold payment for various reasons. And depending on the policies of the payer, it's all different. So payment sometimes is withheld until you send a copy of the medical note and it's submitted. And if they think it's appropriate and it justifies use of whatever the code or modifier, they'll either deny it or pay it. If it's denied, there's an opportunity for appeal, which is the term reconsideration. But ultimately, the final decision is made by the insurance company. And the physician, if it's denied, the physician doesn't get paid. And by contract, they're not allowed to seek payment from the patient unless something called an ABN or advanced beneficiary notice is signed. So when you provide care, there's really no guarantee what you're going to get paid or if you're going to get paid. That's just kind of the way healthcare works.
Okay, so I want to just touch on one point.
Yeah.
If they deny a claim, you cannot get payment from the patient.
Correct.
And why is that?
Because you are a contracted provider with the insurance company, and by the contract, you've agreed that you will provide these services if they deem it's appropriate, and you're not allowed to seek further payment from the patient. It's to protect the patient from us just saying,
Right.
give us more money.
Okay. So, go ahead, Alan.
Okay, you said about UC Canadian, there's no insurance coverage for them, that they are independent.
Some of them have Medicare, believe it or not. They have like, they're married to American, or they have been living in the States for a long time, or they'll pay cash.
Okay,
But the ones I've seen, surprisingly, worked in the States for a long time were Canadian, because we're 1 hour from Canada. Yeah.
So sorry, I don't want to interrupt everyone, but I just want to make sure we're really clear on all of this. So I go to a dermatologist or any doctor, and I pay a copay potentially. I have the service.
Yeah.
And then sometimes I get a bill that says, your insurance covered this part, you owe this part. So how is that different from what you're saying?
So what happens is, let's say, so we don't control what we get paid. So for the same service with different insurance companies, I could get $20, $100. So everyone has their own charge register. We just have to kind of just make it up. So let's say I charge $100 for a service and I bill an insurance company, and they're like, okay, for this procedure, we think it's worth $80. So then they will pay us $80, and that $20, we don't get the difference. That's just, we're contracted that this service is worth $80.
Okay.
But if we submit the bill and say, we did this procedure, $100, and they're like, well, I don't think this is covered, then it's like, you get nothing.
You get nothing.
That's it. Well, you can appeal.
So where does the $20 go to that I, as a patient, am being told?
Nowhere. And that's the balance billing that people talk about. I mean, correct me if I'm wrong, but that's, if you notice, like for the same service, say skin biopsy, I will probably charge a different amount than UVM versus Rutland. But if it's all one insurance company, we're probably all getting reimbursed the same, but there's no transparency. I don't know what UVM is getting.
Right.
Versus us. It's all,
Okay.
it's a contract, and we don't decide anything about the prices.
Okay, so we're gonna ask one more question on this, and then I am gonna set this aside because it's not completely
Yeah.
pertinent to what we're talking about. We can come back to it then, but go ahead, Leslie.
I'm just curious, you mentioned all these different insurance companies. Everyone has a different form and a different process? There's no consistency at all?
No, there is like these clearing warehouses where you can kind of submit to the central, and it kind of works, but sometimes like when it's difficult, we call it drop the paper. So you print out a piece of paper that's a kind of standard form and you hand fill it out. Then you snail mail it to the insurance company. Sometimes you have to get the form from the insurance company, which is a standard one.
Yeah, I thought there was a standard form. What was that called?
Yeah, that's when I hear the staff, because I sit 3 feet away from our front staff, they'll say, well, we're going to drop it to paper, and I see them print it out and try to fill it out.
Okay, great, sorry. I will try not to interrupt.
So that was kind of the background of what's going on. So just to take a step back, I know most of you are not familiar with the coding and claims editing process. I mean, speak now. I don't want to.
The only one is.
Okay, so we're going to give a quick coding 101 on coding and claims editing. Okay. So when I see a patient as a doctor, based on the clinical services I perform, I see the patient, history and physical, exam, I talk to the patient, I have a plan, and then I document in my medical record. My services are translated into a 5-digit CPT code. So CPT code is short for current procedural terminology. In the handout I gave you, there is a link if you want to look at all the procedures. The book's maybe pretty big. Okay, so each code describes in excruciating detail the standardized description for every medical procedure that is performed. So if I do like a skin biopsy, there's different types of skin biopsies. There's tangential shave, there's punch biopsy, and it explains what's included in that code. Okay, so CPT code is generated. I have to choose it and type it in. And then there's a subset of CPT codes called E&M codes, we call it, or evaluation and management codes. And these are the most common types of codes for office visits. And again, there's also a link to that if you want to look at all of them. Those are maintained by the American Medical Association. There's a CPT editorial panel. And the most common examples of codes that you're probably familiar with in the office visit are different levels, such as a 99202, 99212, 91203. You might see those on your personal explanation of benefits when you see patients. Sometimes the codes are not there. And that's for a new office level visit patient, low complexity, medium complexity, either new or established. And there's also very detailed descriptions of what it means to qualify for those types of visits. And most physicians and providers take coding classes every couple of years whenever there's new coding about how to do it. There's like a whole coding matrix. When there were new coding rules a year or two ago, I took a 2-day course, how to code, how do you know when you're billing a level 2 or 3 or 4, what constitutes it? So a lot of ongoing education that most people do. So after you've had your office visit code, which is a type of CPT code, and any other CPT code procedures, you can add a modifier to the CPT codes. So a medical coding modifier are 2 characters, letters or numbers, that are appended to a CPT code. And it provides additional information about the medical procedure or service or involved. So an example of a modifier could include providing the anatomical location of the procedure. So if you did something on the knee, you would have to specify left as your modifier for left. They call laterality, or right. You would have to note if more than one provider performed the service or procedure. Sometimes in surgeries, you have multiple people helping. If more than one location was involved, if more than one procedure was involved, if telemedicine was provided. So it's a way to annotate like, okay, you provided the service, anything else special we need to know about it. So the 2 specific modifiers that I'm going to talk about today in terms of my personal experience, how it's affected our office, are the modifier 25 and modifier 59. So modifier 25 is added when a significant separate, I'm quoting from the CPT code, identifiable evaluation management service is provided by the same physician or other qualified healthcare professional on the same day as the first procedure or other service. So a typical example is I'm seeing a patient for psoriasis, I'm looking through psoriasis, I see a suspicious lesion, worried it's skin cancer, I'm recommending biopsying it. So that I've done the visit for psoriasis and, I'm worried about the skin cancer, I want to do a biopsy. That's a procedure. So E&M code for psoriasis, separate CPT code for the biopsy, I would have to put a 25 modifier on the office saying I did a separate identifiable evaluation management procedure. There's also a 59 modifier, and that's when a distinct procedural service is offered on the same date as another procedural service. So say that patient, I saw psoriasis, biopsy to rule out a skin cancer, and they're like, hey, I have this really painful wart on the bottom of my foot. Can you take a look at it and treat it? Say I look at it, treat it, I freeze it with liquid nitrogen. That's a second procedure from the biopsy. So then I would have to add a 59 modifier. So that's kind of how we generate our coding and billing to submit to the insurance company.
So I'm going to just stop you right there because this piece is really important to what the rest of this conversation is going to be about. So are there any questions right now on what she just said? Art?
Yes. These codes are all national codes?
Yes, they're standardized, and now that we're all in an electronic health record, you pick it from a list. You have to, you don't make them up, yeah.
Right. Okay, so they're a national code.
Mm-hmm.
Do you, just for your own personal, do you input that?
Yes, I do all of
physically
it.
do
And when I was at UVM, I did that too, yes.
Okay, there's not a clerical person?
No, there are people that hire professional coders and billers, and I do know that there are providers in the state where they're not that up to date on this, but I would say the majority of doctors, it's part of your standard
It's
training.
part of your-
I had training during my residency on how to code and bill. I did my own coding and billing during residency to learn how, with an attending supervising me.
And one final question, not to
Yeah.
hog the show here, but how much time does it take for an average patient? Say, because I've been a dermatologist, had skin cancer at
Yeah.
one point. How, for one thing, how much would that take?
To enter these
Yeah.
codes? Probably 3 to 5 minutes. You have to, you're usually put in at the end of the day.
Once you know 'em.
You're looking at the note, yeah. It ends up being multiple. You look at the note and you have to, I usually have a chart with me and you look and say, okay, you disqualify. And then it's a lot of clicking. It's faster on paper. On old days paper, you would check off the thing and draw lines to what linked to what. Yeah.
And it goes to a national site that then
Some,
sends it to
yeah.
the insurance companies?
Or some you have to send separately, but in general, I'm going to ask.
So we'll get to that.
Yeah, all
We'll get to
right.
that question. Leslie, and then
You
Melanie.
just asked all my questions. Thank
Okay.
you.
Melanie?
And in the world of medicine, is this a common thing that most physicians are doing, coding with these different modifiers? So that
Yes.
This is not uncommon.
So I would say you see a well visit, need a vaccine, that's vaccination, that's a procedure. But I would say in dermatology, we have been particularly affected by these modifiers because we're a very procedure heavy specialty. And it's what I described to you, that scenario is very common. I would say maybe 50 or 60% of my patients need a procedure. I'm not, it's not, I do some skin exams where everything's great and you walk out the door. But the reason why they're seeing us is they've had a history of skin cancer and we're constantly taking them off and diagnosing them.
And if someone's coming in for an annual dermatology exam and you see something, the same process applies, right? So it'd be one code for the annual exam.
The reason why they're coming is history of melanoma, skin cancer screening. They're not necessarily coming in for a procedure. I don't know if they need a procedure.
Right.
Yeah.
Okay. Great. Thank you.
Okay. So in addition to all the CPT codes, you also have to add a diagnosis to your visit and the claim. And that's another whole standardized terminology language called ICD-10 or International Classification of Disease Codes. There's a big history of why it was originally in the WHO to track mortality, but in reality now it's used in our coding world. And it explains what diagnosis or disorder the patient may have had to need for the appointment or procedure. So ICD-10, what we're using, the world is, I think, is using now ICD-11, we're a little bit behind, is maintained by the National Center for Health Statistics. Some examples of codes used in dermatology is, like I've mentioned, psoriasis has its own special code. Squamous cell carcinoma of skin of nose, very specific. There's one for arm, leg is C44.321. So that's what it sounds like. Hemangioma of skin and subcutaneous tissue, D18.01. Factitial dermatitis, L98.1. Those are kind of examples. Another big book, probably somewhere. Look it up. In the old days, we would have to look it up if it was a rare diagnosis. Now the computer systems have it. You basically type in your text and it lists the codes and you pick the one that you think is best fit. So once I have the codes, so my diagnosis codes, my CPT codes, I put all the modifiers pointing them to what is associated with what that I provided usually in our EHR. We submit it. There are various ways to submit it, but in general, it's electronic. That's where I hand it off to my front staff. They submit it, but I put in all the codes and matching. Then it sends to the payer and they compile it into what's called now the claim. Okay. And then this claim, as I mentioned, contains all the CPT codes with the relevant diagnoses for the services I've rendered to the patient. And it's sent off and we just wait for the payer for hopefully reimbursement. So the insurance company will review it. There's many ways to review it, but I mentioned now there's these computer algorithms, you know, I just want to say AI is all the buzz now. This is not AI, it's an algorithm. But they'll verify that the services align with the patient's coverage and they process it, everything checks out. The insurance company pays me according to whatever agreed upon rate that we talked about. That's not anything we control. And then paid. So in simple terms to summarize, this is the coding billing claims 101. Medical billing and coding involves translating what a healthcare provider does into these special codes into a claim, and it's then sent to the insurance company to get paid for the services provided to the patient. So they're the middleman, what goes on. And the turnaround time for payment varies. It can take weeks to months. So there's a lag in reimbursement. And this lag has just worsened as insurance companies institute new layers of claim edits and administrative requirements. Okay, so as I mentioned, in terms of my personal experience, we're a small office of 2 physicians and a very small operating margin. So every dollar we make actually goes to paying the salary of our staff, you know, the rent. We don't outsource our billing or coding. You know, we do our own laundry for the gown. Someone brings it home and we wash it. You know, we take out the trash at the end of the day. So very low operating margin. That's what makes us able to stay open. And what that means is if there's a long delay in insurance reimbursements, it's really challenging to keep the lights on and to run a business. We run very lean, like I mentioned, no office manager. We don't outsource our coding or billing. We train our own front staff to do this, submitting the bill. They're not certified coders or billers. We rely on ourselves and do our own self-education. So it's elbow grease of 2 doctors and 5 very dedicated staff that wear many hats. And we've had to hire actually 2 remote assistants this year because of all of this administrative burden to help just to submit the claims. Okay, so what happened was in, I think, November of 2021, there was a introductory email from Blue Cross Blue Shield saying, hey, you know, we are putting in a new claims editing process. They were already doing editing. There were other programs. I think it's a 3rd one called Covidity and more to come. And then a larger email was sent. And I would say it was sent to our administrative person who, you know, they're not coders. They didn't really tell us, but it's this pretty onerous document. It was so thick, I couldn't even staple it. Staples came out. I had to put a binder of, these are all the new edits that are going to happen. So it's not just a 25 or 59. I'm talking about these 2 personally because that's what affected our practice about. Each code, what's going to happen, which are going to be what's happening. So it's kind of hard to go through this and understand this, but it takes a while to stick. And then January 1st happened and we read it, but we didn't really think too hard about the impact. But suddenly we weren't getting paid. Blue Cross Shield, anytime we did a procedure, an office visit, we weren't paid. And there was a little bit of small panic in our office because we had to pay our staff and we don't have this big slush fund. So we did submit the claims, you know, it was difficult, but this new claims editing process that is a computer program algorithm that automatically just withholds the claim if you have a 25 or 59. There's no oh, this is appropriate. Oh, they're just held across the board. And that is what has affected our specialty the most. And that's when we did an office visit and a procedure on the same day. And as mentioned, the most common scenario was skin exam, biopsy, psoriasis, or yes. Go ahead.
So does that mean that you automatically have to take you
Yes.
every time?
Yes.
For 60% of your...
Yes. Okay. So panic ensued, but we're going to try. We did start to submit the claims, but what happened was you have to submit individually, 25 denied, you have to find the claim, print the note, and send an individual email, match it up. You couldn't send all 25 claims with edit. It's 25 individual emails with the claim and the office visit. So a lot of work. This is why we had to hire another person. So we had to make so I kind of went over the typical example of the coding, so I'm not going to repeat it. So we just said it wasn't attainable. Like mentally, it was really stressful. So we made the very unfortunate decision, and there are other associates here that are going to talk about, once you submit the claim, it's really fraught with problems, and they will elaborate in the details of these.
Claim or the appeal?
The appeal and the claim about emails, and I'm not going to go into the details with other people. But what we had to do, because we're so small, is unfortunately, I feel horrible saying this, but we had on the schedule and we flagged every patient with Blue Cross Blue Shield. And honestly, I forgot most of the time, but my MA would remind me. And when I was about to do a procedure, my MA would say, this patient has Blue Cross Blue Shield. So I started to be very transparent with our local patients and explain what was happening. And I said, look, would you be willing to come back on a later date if it was a non-urgent procedure to get the biopsy? And graciously, a lot of our local patients were willing to do that, even if it was going to cost them another day of work off, maybe additional copay, but they did that. And the reason why is because if these two appointments happen on two separate days, you can still bill for them separately, and there's no modifier. So then you're reimbursed, and there's no extra paperwork burden or payment delays. Okay, so I'm very thankful that our patients were understanding. The people that were far away, it wasn't even a conversation. We just gave good care, and we had to eat the cost if we weren't going to get paid eventually. But our wait times were already very long in our specialties. So to have these additional visits for separate procedures, it takes away visit slots for other patients that really need to get in. And quite honestly, we didn't have the space in our schedule. So we double booked them, and we were running late, but this is just what we had to do to give good care. So, this new claims editing process of across the board, if you have a 25% modifier, it's automatically withheld, really put us in a difficult position of really needing to do the right thing for my patients and having to make decisions for the survival of a small medical office. And I want to give high quality care to my patients, and I don't want to have to be concerned about whether I'm going to get paid to keep the office open. So, if I see a patient, I suspect a melanoma, I don't ever want to delay a procedure due to an administrative burden. So kind of that's the lay of the land. And I'm just, in summary, just saying, mentally, this year has been exhausting because of this. And we did have a meeting earlier with Blue Cross Blue Shield. And initially, when I asked them, why are you doing this? You already have two claims editing process. One of the feedbacks was, well, we want to make sure that everyone is coding properly, and that our members are getting what they're paying for and we're not billing incorrectly. And we were arguing, I know how to bill. I'm pretty confident. And they were actually willing. They came to our office. We gave them 30 of our notes. We had a coder look. We did not have any mistakes. So their rationale to say, we want to make sure, that's great. I would rather you review it. And if it's incorrect, we're happy to give you the money back, but it's the withholding the payment first and waiting that has caused quite a headache. And I'll be honest and say, I, born and raised in the United States, I just assumed I would live the rest of my life here, but part of me is this is not what I signed up for. I went to medical school in Canada, and I'm seriously thinking maybe I should go visit Canada. The borders are open. They're now accepting American doctors board certification. Should I work there? I never thought ever I would leave this country actually until all of this has been happening, or become employed again, or just don't take insurance. That's how hard it is for small offices. And we are a very small office. When there's a lot of the other community practices, they do have billers and coders, but it's just two of us, three other people, but we're doing our best. And, I want to give care. I feel like we're providing a really critical access to patients north of Chittenden County.
So that was wonderful.
Yeah.
I know Alyssa has a question, and I have a couple, and there might be some more.
I have two questions specifically to something that you had said. Do you have recollection of when that panic ensued, late January of 23, early February, when all these claim rejections were coming in? Do you have any recollection about your knowledge of how to appeal and the process for appeal?
It was very difficult to navigate. So I called our provider representative, and they were kind of this is the way it is. I'm is there any recourse any other way? And they were nope, not going away. This is what you have to do. And I honestly, because, I was just trying to see patients, I kind of let my colleague and the staff kind of just figure it out. And they were calling and they were emailing, doing what they were told, trying to find the claims. And the claim edits, when you get back, sometimes the wording is very unclear, like why it was denied. Because when you're looking, you're like, I think this is appropriate. Like there's not clear feedback, like this was denied because this is not it's hard to read the language. It's not like a written statement of what's going on.
I also wondered if, separate from the modifier issues, first of all, I would imagine you'd have a lot of laterality in your specialty.
It means left and right.
Left and right. A lot of LTs.
No, but I do know, like if we do a Uniboot, I used to do left Uniboot, right Uniboot, it gets denied. So now I know it has to be bilateral procedure for me, which is a different modifier. But there's a modifier for left or right or left and right. And you never know if you do a left and right procedure, do you put bilateral or do you put left and right? And every insurance is different. So some of them will take bilateral, other you have to do left and right separately. It's just like this clicking game on the computer and back and forth, back and forth.
And I wondered if you were, so separate from the modifier issue, I wondered if you were getting rejections also for primary diagnosis is an invalid.
Yes, anything that ends in 0.9, we now know. Never put a primary diagnosis that ends in 0.9, which is like unspecified, which is a lot of stuff we do. Like, I don't know what it is, so we have to put a very vague, like, I think it's a cancer, maybe not, like D23.9, and sometimes that's denied. In the coding world, you can't have a mole and a cherry angioma at the same time. These are two benign lesions. If you put both diagnoses on, the whole claim gets denied. I don't know why. It's just the computer program just spits it out. So now whenever anyone has like a little red spot, we note it in the physical exam. I never put in the diagnosis because the claim gets denied. It's just very.
So you're withholding diagnoses.
Well, because the claim gets denied. But it's irrelevant to the patient's care in terms of, we're not really managing it. We're just telling them what it is and reassuring.
But it stops from getting a claim.
Yeah.
So you're not sending full significant information regarding diagnosis coding that you actually have, but you're not sending it specifically so that you're.
It's documented in the note as a diagnosis and in the physical exam, but we just don't send
You don't send it.
the code.
And one last question. When you started doing the appeals and you were sending them individually one per email along with your office notes, I wondered what the time frame of getting a response to the appeal, how you were receiving a response to the appeal, and if you have a sense of maybe the percentage of your documentation that you sent via email, not Blue Cross coming into your office and looking at them. I'm wondering if you have a sense of how many of those were actually paid on appeal or were just then denied on appeal.
So I was going to say is, I know my associates are going to speak in much more detail. We had a big slew in January, February that got denied, and then we basically stopped putting 25, 59 towards the end of the year because it was, we don't have that much data, but the other people are going to speak. But in the beginning, though, it was very hard to track. Like our EHR doesn't have robust analytics. You needed like a separate Excel sheet to track what. But I did trace a couple of them. I kept my in basket, and it took like months of back and forth, and ultimately I kind of gave up. I don't even know if I got paid or not. I just kind of said, I just have to move on because it was like just mentally stressful. I mean, I was trying to focus on patient care, being a good doctor.
Making me mentally stressed.
I want to say, I love
Making me
seeing
stressed
patients,
listening
and
to it.
part of me is like, I just want to take good care of my patients and not worry about this part, but I have to. I'm an independent practice. I'm very close to the business side. All the staff sit like within 5 feet of us. They're not sitting separately somewhere, so.
Thank you.
So we have a couple questions lined up. Mari, and then Leslie, did you have one? And then Art. You don't have to look at her. Just she'll talk from behind. It's okay.
Yeah, don't turn around.
Yeah, the camera's there, so she.
This is very stressful to hear, and I'm thinking about the experience as a patient, especially if a patient has any awareness of what is going on behind the scenes and how stressed providers are right now, both with time constraints, being told you can only spend 15 minutes with a patient for this condition, But you're going to need to spend more time than that. And so I just see it as a barrier for patients too. I know I already do this when I know that I need something from my primary care provider. If I make an appointment for one thing, I'm really, really careful not to, like, on the day of the appointment, add something that's, oh, this has been bothering me too. So there may be barrier. It's just another barrier for patients receiving good care, especially if they have any sense of what's going on behind the scenes.
Good point, Mari. Leslie?
I'm kind of wondering who's in charge. It sounds like it's chaos.
Insurance companies are in charge,
So
I
each
feel like.
individual. So there's no
Yeah.
overarching DFR or a governmental
we'll hear
entity at the
from-
Fed level.
We'll hear from DFR later on of what they feel their role is.
That's really, I mean, it sounds ridiculous.
I will tell you,
I'm really
like-
sorry, that's all I can say.
Yeah, so on the national trend, Cigna a couple years ago tried to just say, you can't do a procedure office visit on the same day, just period. And there was a big national putback. Everybody was like, this is bad patient care. So they ultimately reneged, but they at least announced and said, this is what we're thinking of doing. But that's just where the trend is going. I'm not going to be surprised if another insurance company does something. I don't know what they're going to ferret us next.
So
Gotta be prepared.
Are there, if I may, or societies, national level, really looking at this and thinking about it, and we can ask your question?
Yep, keep the questions, that's not a Julie question.
Yeah.
Keep that question
Yeah.
for future. Art?
Just a quick question. When I hear stuff like this, judging from my own work experience, what it creates is the workaround.
Yes, this is a workaround that I hated doing.
Right, and I can foresee you saying, well, if that won't work, we'll put this code in and it's the same money. I mean, does that happen? Is that thought process what's created here? The workaround, the off coding to make the money work? I'm not trying to, I just wonder, and you may get in trouble for doing,
Well, no, it's unclear. So for instance, like if somebody I remember a specific one claim, we're not making up stuff. We're just trying to figure out what is the right code that will get paid. Because there are often more than one ICD-10 code that will satisfy the diagnosis. Like for instance, like somebody came in for just a benign, they had a spot of concern. It was a benign mole. There's no code for nevire mole in ICD-10. It's like benign neoplasm. So I put that code in and it got denied. They're like, you're not going to get paid to see a benign lesion. So I'm looking for another code. And there's other skin condition or benign neoplasm of the arm. But you're picking the same diagnosis, but it's just a different code. It's not like you're completely changing it.
All right,
because you can't figure out it's the computer. It's not a person. Why is the computer not accepting this? So you just put in a different one, they submit, and I get a message back this was denied. So I'm like, and I go through the list. I'm like, well, this is the same thing. And I just pick it.
Translating to 3 different languages.
Yeah.
It's all the same thing, but
Yeah.
just being able to speak the language of that insurance
Yes.
company, with that code.
Yes.
So I have a couple questions and then we'll move on. So the workaround though, so to summarize, your workaround is a couple things. It is either you are asking the patient to come back for that second procedure, which is causing more work for you, more work for your schedulers, more work for the patient, and access problems potentially for other patients. Or the workaround is you're putting it through and it's getting denied, and then you're just not getting paid.
Yes. Or you fight. But some offices, I think, don't have the energy to fight. And
Yeah. So my other question is, and this can be a very broad number because I don't want anything personal coming out, but you said you had to hire a person or two. That and other expenses that have been incurred, can you give a ballpark of what this has cost just for staffing changes that you've had to do?
I think it's going to be hard for you because I'm not that close to numbers because my colleague is really the person. We hired one additional virtual assistant.
Okay, so that's one.
And we hired a virtual assistant because it was cheaper.
And then you said that you mentioned Blue Cross Blue Shield. Are any other insurance companies doing this that you've worked with? Or something similar?
Not that I'm aware of. And just to clarify, after this was so stressful, Blue Cross Blue Shield heard us and they did the audit of our notes and found all our coding was good. They agreed for our office because the people that were not high users of this modifier weren't being held to the edit. They've lifted it. So we have since had to.
Okay, that was my next question.
So they're not withholding the
25-50 fine for every clinic. So it's not treating everyone fair. It's the people that are high utilizers of this. So some offices that aren't procedure heavy weren't affected by this, which is that fair? I don't know.
So it wasn't a broad,
I think initially it might have been, but then.
and then they started?
Yeah.
Okay.
And those offices got a letter saying they weren't going to withhold it. But all the other stuff, whatever's in here is still going on.
Right.
Yeah.
And did they reach out to you and say, we want to come in and figure out how to make this better for you? Or did you have to reach out to them to say, we want you to come in and educate us?
There was a meeting at Blue Cross Blue Shield that a lot of stakeholders were there, like Rutland, CHC, and I came representing Health First in Paxton, just myself. And I think they saw how stressed I was. So at the end of the meeting, they said for us, reach out, we'll have a coder come out and look at your notes.
Okay, thank you.
I just wanted I wanted to point out, they gave you an exemption on the modifier issue. They did not give you an exemption on all the other claims edits. So
No, we were
still having to
yes,
drop off diagnosis codes.
yes, that's still going on.
And you still have this extra person, virtual
Yes.
person, because you're still doing it. Okay. Thank you very much.
I want to thank everyone for your time and
Yeah,
I
and thank you for the care.
appreciate the opportunity and privilege to speak. Thank you.
That was very helpful.
We'd love to help you.
Yes. I think you've given us all a headache now, but that's not.
I was trying to tell a story.
Yes. No, that was great. So now we have Erica Brown from Community Health Centers of Burlington. Hi, Erica. Hello. Welcome. So if you can introduce yourself for the record and then start your testimony.
Sure. My name is Erica Brown. I'm the Director of Patient Accounts for the Community Health Centers of Burlington, the federally qualified health center serving Chittenden and Southern Grand Isle counties. I'd like to thank everyone here for being here today and for hearing about the important work that we do, especially related to, how that is impacting claims as well as payment. Just as a quick background, the Community Health Centers has been around since 1971, understanding and addressing the needs of our community members regardless of financial status or life circumstance. We currently care for 32,000 patients, providing medical, dental, counseling, and psychiatry services, among many other standardized safety net programs like our homeless health care program. On average, we have about 135 visits per year. And in a year's time, we submit on average primary claims only 178,000 claims per year. 138,000 visits per year. And that equates to roughly 178,000 primary claims. That doesn't account for secondary or tertiary claims.
So can I just clarify? So that means for one patient visit, you might have 2 claims.
Yeah.
Or 3.
Or 3.
We could have 3, yes. And Blue Cross Blue Shield is actually our largest commercial payer at this time. The edits that the last person spoke of, the Cotiviti edits with Blue Cross Blue Shield came into effect in December of 2022. So like the other person, it really became evident in, February or so of 2023 that there was an issue at hand. Since these edits have been implemented, we've had a significant increase of about 33% of claim denials increase. The claim denials were further complicated to work since the reason for denials falls into a general category, which could account for any one of many denial reasons. So it makes it a little bit more difficult to tease out the actual reason for denial. After coding review, many of these denials, they saw no issue at all on the coding. And so this increased our need to contact our call center because from a denial coding and perspective, there was no issue at hand. No reason for denial from our standpoint. The Blue Cross Blue Shield call center has had a 2+ hour hold times on average consistently for the last couple of years. So the inability to be able to reach the call center further delayed any insight to resolve the unpaid claim issue or further understand what next action was needed.
Looking at, I just want to make sure that we clarify that. So because these are being denied, you're having to call the call center, which has a 2.5 hour wait to figure out what the next step is.
2+ hours, yes.
Okay, thank you.
We were then given an email address after contacting our provider rep to say we aren't getting anywhere. These denials are piling up. We can't make heads or tails of why we're not being paid, and yet we can't get through to the claims call center. So we were given an email to send questions to, and it could be a 30-day wait to get a response. These emails are sent encrypted because they do hold private patient information. So the emails do expire after 30 days. So then what we were finding is when we weren't getting responses, or we'd get a response at 35 days saying they can't open our emails because they expire, because they have private information in them.
Eric, can I stop you there? Art?
Yeah, and you may have covered it here, and maybe I zoned out in hearing it. Did this happen with Blue Cross Blue Shield? Has it always been that way, or did something happen? Did they reorganize and change?
They turned on additional edits in the analytics that the last person spoke of. Were
Okay.
turned on in December of 2022.
Okay. All right.
And
I missed
it really
that part.
began
Okay.
to hit, because there's a 30-day, roughly it's about 30 days to adjudicate or fully process a claim.
And these are turned on electronically, so it's banging up against it in the
Exactly.
versus a person making the call.
That's right.
All right. Okay. Just so I understand. Thank you.
Sorry, one more question, Leslie.
I'm just curious, it looks like you're reading from your testimony. Could you submit that so we could have it?
I sure
I
can.
appreciate that.
Yes.
But to, yeah.
Yeah, to Claire, we'll have you submit it to Claire.
Okay.
She'll reach out to.
Okay. So, when the emails come back that either they aren't answered at all, or we couldn't open it, we have to go back through. And I mean, just to note, that's a high volume of emails being sent to then you're just like bulk, resending them all because you're not sure which are being kicked back. So this went on throughout 2023, and with constant communication with the provider rep, just trying so hard to get some resolution. In November of 2023, there was a meeting that the last person spoke about that occurred. And during that, there were primary care groups and other stakeholders. And at that time, we were given an additional document with some clarification on steps to help remedy these unpaid claims. And an additional email address we were given separate from the prior. Since November, in the claims that we've sent into the chart notes to this new email that we've been given, we've only received one response back. The process is that if your Blue Cross Blue Shield Vermont member, if their member is Blue Cross Blue Shield Vermont.
So the patient.
Yes, the patient has that type of insurance. The manual review, when you send the chart notes to this special email address, the manual review for Blue Cross Blue Shield Vermont members can take up to 30 days. So now we're at best at 60 days. So it takes 30 days for the initial claim processing. If it's out of state Blue Cross, it could take an additional 30 days beyond that. So 60 days plus 30 for initial. So we're really at minimum 60 days and 90 days at this point, in best case scenario, in order for final adjudication or payment processing. And when you send them, you're supposed to wait and get an acknowledgement within 5 days. And if you don't get acknowledgement that they received it in 5 days, then you're supposed to reach out to that same email again. So this is just an immense amount of tracking to do to try to, just get to the bottom of the issue, so to speak. So the 25 modifier issue that the last person spoke of is definitely hitting us as well. And I won't go into the details because she already did. But really, we do our best to give comprehensive care to patients, and part of that is recognizing social determinants of health, such as transportation, which is a real thing for our patients. Many patients struggle to get appointments, time off work, so it's imperative, if both services can be rendered in one day, that our providers are able to do so for best patient care. In a climate where access to care is already an issue, we do our best to meet patients' needs. Delays in payment for these visits where two services are rendered and warrant the modifier, which then causes a denial of payment and the review necessary, causes issues for our health center. We currently are bearing that burden at our health center. Other issues that have come up with this claim editing system, in addition to the 25 modifier, is the redundancy of information needed. There was some talk about the laterality. It's just really, it's redundant because often the diagnosis code given specifies that laterality. So we haven't seen other payers requiring it, and it's duplicative information, again, cause for denial. In summary, I would just say that these changes in claim processing has had an immense effect on our payments and timing of such. It's increased the administrative burden for all of coding and billing. It's delayed bills to our patients. And I think that's really important because a lot of these patients are gonna owe if and when we're paid. And for a patient to have a service and not get a bill for 60 or 90 days, that's really troubling for them. Staffing is an issue as well. We're just talking about burnout. We're seeing a lot of burnout. We've had staff leave to work at Costco. I mean, seasoned billers of 20 years that are like, it's hard to not feel successful. And, part of their success is obviously keeping the money flowing in. Claims. So we continue to care for our patients. However, in a climate where margins are already slim, this additional work to gain payment for services that we've actually rendered is really unfavorable for all. Even from the payer's standpoint, their review is manual. Those are people doing those reviews. Patients for access of care and their delayed bills, and the health center to carry such a large administrative task and to wait 90 days plus for payment. So
Thank you.
thank you for your time.
I know we have questions, Art and then Alyssa.
Yeah, is this problem only with Blue Cross Blue Shield?
It's biggest with Blue Cross Blue Shield because of it's called Cotiviti. It's the edit system they've turned on.
Right, but the other providers is not as much,
Correct.
but is still a problem, or?
The denial rate is nowhere
No
near.
different, okay.
It's nowhere
Near.
near what we're seeing with Blue Cross.
How about our state stuff, Medicaid, that's fine?
Billing is a little different for us because we're what's called encounter rated. So billing is a little bit different. But no, I wouldn't say we're not encountering these.
These types of the numbers of, okay, thank you.
Just for our contracts are different.
Just one of the, you guys deal with TRICARE?
Yes.
You do, okay.
Yeah.
Thank you.
I'm just going to jump in real quick, sorry. Are you seeing, so November 23rd, you had this meeting, you got a one-page informational, you got a new email. Are you still seeing every time you submit something with this 25 or 59, it is automatically denied?
It is denied. Sometimes one of the services will be paid.
Okay.
The rest is denied, but we're not getting feedback from the email.
As to what you can do to rectify the situation?
Meaning, we're sending the chart notes and we're needing
Not
to
hearing
send at 5 days, we're not getting this back. And we're not getting any confirmation. So it's kind of out there, and then all of a sudden you're 45 days in and
You haven't
needing
gotten,
to resend it to start the clock again.
okay, thank you. Alyssa?
I have a couple questions, but to follow up on Art, are you having this problem with Medicare?
We also have a slightly different contract similar to our Medicaid, so it isn't hitting.
HC.
That's right, because we're an FQHC, so it is, I can't really speak to that because our billing is different for Medicare.
You had talked about the time frame for all these steps. And it reminded me of testimony we actually took yesterday because we've been speaking with VHI, which administers the teacher's health plan. And I wondered if you could speak on, because of the denials from Blue Cross Blue Shield, the additional then time you need to wait to receive payment from their third-party administrators for their HRAs, and if that also adds additional time.
Right, because we're not going to get paid from an HRA until the claim adjudicates and shows a actual balance due to patient. To the other person's testimony, you can't balance bill a patient unless the insurance indicates that is due from patient.
So sometimes you can already be at 90 days and then you've got to wait probably another 30 to 60 to get the HRA to re-adjudicate the original denial and then pay you.
Correct.
So you can be waiting sometimes 6 months if you get a response.
Have you had to hire any more people?
We are in talks of doing so. There is a need. We have 2 certified coders, and they are spending much of their day working these denials. So I forgot to mention that in November, when we all met, we were told that we can request from our provider rep a weekly denial list that gives more detail of reason for denial. And so, our coders and we have a designated biller that is managing those as we speak.
And, sorry, can you explain the difference between, and maybe there isn't one, certified coder and a coder? Or?
Yeah, no, if you're right.
If you're a coder, you're certified?
Yes.
Okay. Alyssa?
I wanted to ask you also the same question that I had asked the previous witness. Have you been tracking how many of the appeals that you have sent, and what is your success rate in actually receiving payment on those appeals?
We have
done. What the percentage of that is?
Of all the appeals that we have sent since November, I believe there's been, I think they said around 40 or so. We've received feedback on 1. So we're still trying to work through and do a second round of justification, which it requires, right, citing, coding why. So you've already sent your notes. So now you're going to write something up that says, we disagree with your decision. And then you cite the coding rules and regulations as to why.
I'm sorry. So since January of 23, you've only sent appeals on 40 denied claims?
In November, we were given the new email address.
Okay.
And at that time, in November, we sent those.
Yeah.
Prior to that, we were sending the other emails requesting review and explanation. It wasn't until November that we were given this new email address to send the chart notes to.
Okay. So do you know how many claims at this point you have just written off?
We haven't written them off. We're holding them on our aged AR because we're not giving up.
But how many have you not been paid
How
on?
many rejections?
We've been paid on, I believe, one that we've sent since November.
But since January, I mean.
January of 20.
January of 23. No,
Two.
23.
Yep, we're
23,
still
so just-
working through all those denials.
And do you know how many of those denials?
I would have to probably pull a report because we've done it month by month. And because the reason codes are so broad, it's not until November when we started to get the detailed reports that we were then able to parse apart standard denials versus these cotivity denials that are requiring the additional documentation. So where prior to November, it was a big bucket of abyss, it became more detailed in November at least. And that's when we started sending the chart notes. Because prior, all of our emails to the prior requested email address weren't getting there. And I'd gone to our provider rep saying, I think there's an issue with your email. They did say recently that there was. So all that time that we went back and forth saying, we're not getting responses, your call times, there's no coding issues with these, we're not getting payment. We just kept being told to send to the initial email, which was finally deemed not working at one point. So we went and resent everything. So we've been doing this mass resent. So it's hard to track.
And last question, I promise.
That's fine.
I just, again, the same question regarding setting aside the modifier issues. Is the diagnosis coding or the invalid primary diagnosis rejection affecting your practice as well?
It is definitely affecting our practice, but I would say the modifier is bigger on our side. And we're seeing other kind of oddities, like patient came to us, we're denied for duplicate, doesn't make any sense. We saw them once that day. Well, they were seen in another practice completely separate from ours. And so this is the type of denial these are the type of abyss of denials where, we don't have clarification on the fact that you went to two different practices in one day. So you get a duplicate and you're confused. And so we are seeing multitudes of oddities like that. I call them oddities, but the process is the same. And we're not doing anything different but sending in the chart notes because it's coded correctly and we rendered the service.
Thank you.
If you can provide us any data on the number of claims that have been denied, that you've appealed, and that you've won.
I can, sure.
Okay, thank you. And Claire can send you her contact information. If you don't have it, you can send everything to her. Any other questions for Eric?
Yes.
Oh, sorry, Mari. I did see your hand and then I forgot. And you can just look at the camera. You don't need to, Go ahead, Mari.
So this is a comment with a question. I want to highlight the broader systemic crisis. Is
she okay?
Can you hear me okay? Did I?
Yeah, you flinched a little bit, but yeah.
So I just want to highlight this as bad as this is for providers and clinics and for patients. It's also a broader systemic issue, including that pharmacies go through the exact same thing. Some pharmacies are deciding not to use Blue Cross Blue Shield or not to participate for durable medical equipment for the exact same reason. And these kinds of issues are one of the primary reasons that pharmacies are going out of business, or now that in Vermont, pharmacists are allowed to tell patients what something would cost if they paid cash instead of billing insurance. They're going that route, but essentially the revenue for pharmacies is critically bad, and that's why they're going out of business. And I wondered if you have heard of that in your experience with patients, and when you prescribe medications.
I'm a little bit more removed from the clinical side. I could find that. I could ask our chief medical officer. I'm not certain though.
That's okay. And maybe some of the other folks could get back to me if you've had experiences with the pharmacy issue. And sure, if you want to get back to me with anything that you have from your health center, that would be great. Thank you.
Thank you.
Any other questions? Okay, well, thank you so much. Next, we're going to hear from Kelly Lang at UVM Health Network.
I was just making sure it was mornings. Thank you for having me, and my colleagues in the industry have done a great job in explaining the details. So first, my name's Kelly Lang. I'm the Vice President of Managed Care Contracting for the University of Vermont Health Network. So for all 6 hospitals, New York and Vermont. And my team oversees the day-to-day contracting for all payers. We have over 20, more closer to 30. So from TRICARE, Medicare, Medicaid, commercial, self-insured, small specialty contracts, and our value-based programs. So we oversee the revenue coming in from the third-party payers. It's a small team doing, again, shared services to try to be more economical with all our hospitals. And that has really grown over the years in terms of the complexity that we're going to talk about. And just briefly, my history, I have been in the healthcare industry since 2007 after law school, but then Blue Cross Blue Shield Vermont for a long time, ironically. I was their contracting director and then did value-based reform with them. So have definitely been part of this industry, learning in the weeds. Taking a step back, the questions that have been good about do we experience this with all payers? The answer is, and I think it was well stated last, yes, it has really just exploded lately due to the Blue Cross policy. And think about this morning, analogies, and if you're moving or working in your office and you get a bunch of tiny paper cuts and you get annoyed, but they're all just tiny paper cuts. And then if anyone's ever gotten a cardboard box cut, it is like the most painful thing. But you're moving in your office and the paper cuts are annoying, but you're dealing with them. And now all of a sudden you get a cardboard box cut and you can't do anything for the rest of the day because you have a gash in your hand. That's really what this Blue Cross policy made me think about. I didn't get a paper cut. I don't know why that was in my head, but I don't know. It's an industry issue. I'm going to give a couple more examples. The 2559 we've talked about, but given we're a facility, there's ED downcoding. There's policies that go in that the payer can do at any time with brief notice that comes in various forms. So the standardization, while we do have all the same provider billing forms, the 1,500, but we all are using the same forms. But how those forms are processed or used, or the information, the primary diagnosis, what information is on that form is different for every payer. And so that really creates, burden on providers and the workforce. And our important workforce is the clinical staff, but the billers, the admin, the staff that needs to support. So Dr. Lynn can do her job. And so that's really, and I will tell you, they are extremely stressed right now. And there's some that I've had to say, take the rest of the day. We'll get those claims later because they're just sick of not getting responses. And so to give some data points, and my testimony was provided, so I'll just highlight it. As I said, we have more than 20 payers, and getting into the weeds a little bit, because that unfortunately is this issue. That actually requires over 180 different contract setups in our systems. So one payer may have different lines of business you may have heard. So one payer may have Medicare Advantage, commercial, a separate deal for some other specialty, a pharmacy difference. So every time we have to set that up in our system, that's a whole different setup. So it's not just the number of payers, it's the complexity within the payers. On top of that, when we're billing, and did a wonderful 101 on billing, complexity that gets to the patient impact. And I just want to follow up on your $20 copay question. So this is why delay in billing creates complexity for the person, the patient. If we are to get paid $80 on a service, because that's what we agreed to in that example, and your copay was $20, we actually only get $60. you still pay that 20 and total it's 80. So that if these bills and what we're talking about delays, going to, and you get a bill in 6 months and you're like, I don't even remember, you may not pay it. So now we may have that $60 from the payer, but we may now write off that copay because someone isn't paying it. So that's where your copay comes into this issue and delay of billing, or if there's reprocessing, how it hits your benefits. So there's a downstream impact whenever we delay the revenue. So it's not just revenue to the providers. I mean, that's a huge impact, but it's also the downstream impact of how it hits your insurance plan. And again, this can span the system. So that's where this billing process that is uniform is not. Some other points I wanted to highlight, again, noting the current policy environment overall. This is just not prior auths. I know you guys have heard about prior authorizations. We've talked about those for years. These are, again, just billing coding policies. And we get different policies. I have one staff who is an MBA trained young woman who's phenomenal, reading payer policies every week. Like, her talents can go far beyond that, but that's where we have to use her right now. We get estimated 2,100 payer policy changes a year through our hospitals. And the providers here get them, but they don't have that staff. And we're not even capturing most of them, even though I have one staff person for our 6 hospitals. The difference in how we receive notices are PDFs, emails, newsletters, Excel spreadsheets. So you have to dig through. So you get a newsletter that says, this is Provider Celebration Week. And within that newsletter, they may say, and all these codes are now going to be audited. And that's the reality of how communications are sent. Every payer has a different standard. And so again, that's considered notice. And we do negotiate with our payers. We try to make it as standard and require single formats. But whether it's national or local, every payer has differences. I will also say Medicare and Medicaid, but especially in Vermont, we've got a really good connection directly with Medicaid, but also with Medicare, it's much less. And their policies are standard. They're not different. It's just, this is how it is. Sometimes we don't like that, but it's at least you know what you're getting into. And so with those notices, we have to review them. We really focus on the high level information, or high impact, because we don't have time to focus on all the small ones. And then we send this email that is called the payer matrix that pretty much everyone in our organization despises. And it's a long email saying, these are the changes. We summarize in categories, but then that radiology group, we say, you're the expert. Look at it, because we're contracting. We may not have picked up everything. So then now that clinic staff, sometimes it's the provider, sometimes it's the nurse. It varies within our system, and I'll come back to that. Has to look to see what difference it is with Blue Cross or MVP. And so this is a broader issue, but going back to the paper cut, everyone wasn't happy. We're dealing with it. We're trying to negotiate. And then Blue Cross came. And that just really exposed, as much like COVID exposed problems within systems, that really exposed the control payers can just implement policies, provide some notice, but again, the manual that was shown, but not really have explanation. And even when we asked their staff explanation, we didn't get clear answers, and sometimes no answers at all. And so the last part of the general overview in our system, while we are the health network and system, obviously, and all 6 hospitals, but in Vermont, we have critical access. We have 3 very different hospitals. We have different billing impacts at each hospital, and we are trying to support all hospitals, but it's very different, and our staff hasn't grown. We've just moved people to do this work. So I have my one contracting policy person who is supposed to focus on all payers, primarily focusing on Blue Cross right now, but she still is doing every payer. We moved 2 contract analysts to be the person who is pulling a medical record now on the hospital side and submitting that single email. She's an analyst. She should be helping us look at where we're missing out on things where we can improve. And then there's the professional billing side. So you do have hospital and professional. That's a whole different staff. That is, again, pulling medical records, calling Blue Cross, using that weekly spreadsheet, because when you get a denial or a remittance, it was said, the reason code is unclear. It's denied for other visit possibly, but it doesn't tell you why. So that's why Blue Cross has had to take a second step and do the spreadsheet, because the first step doesn't tell you enough. And that is different than other payers. Other payers do have 25 and modifier policies. I don't want to say Blue Cross is the only one. Cigna did backtrack on theirs. MBP has, but a lot of it is post-adjudication, which is an audit. And that November meeting that everyone was talking about, the message was clear to Blue Cross. We want to bill correctly. If we're not billing correctly, show us. I mean, we're not perfect. This policy did make us look and identify a couple of things with emergency billing that we fixed. But we needed to be educated, not just claims stopped in this rework that took till November last year to find out some things. I can just last thing on staffing, to tell you the impact. We have 200 billers and coders overall at UVMC and estimated 30 and 10 CVMC and Porter. We also have New York. I mean, that's healthcare cost. When we get into the cost of this, ultimately the patient impact, and we've talked about here, is this causes healthcare costs to rise. Because if we're getting denied, we need to negotiate higher rates with Blue Cross to make up, we're talking 7 figures here of impact to our health system. And so I can go through more, but I just want to stop there at the high level.
We have a couple questions, Art, and then Ellen.
Yes, my question is, for all the folks who have testified, have you folks gotten together and actually sat down with a person from Blue Cross Blue Shield across the table and talked about this stuff? Or are we just emailing and coding and computers kicking stuff back?
Yeah, it's been a very proactive, and this is one of the, not few, but as a system, because this is impacting every hospital provider, you see the 3. That was that November meeting was with Blue Cross. It was, I call it the big family meeting. And that was also, we have met with our counterpart. We meet weekly with them. I'm sure I can't speak for my colleagues, but yes, this has been.
Okay, so they were face-to-face.
Face-to-face.
That happen. Is there any solution in sight? I mean, are they offering some solutions to this?
So what they have offered, so they have similar to what Dr. Lynn described, and it's very much us being proactive. But at first they said they needed more data and time. So they needed Cotiviti, their vendor, to pull reports to see if we're billing properly, and basically our compliance standard. And they said once they'd have data, they would consider turning off codes, the modifiers, the policy, one at a time. So for example, they ran one report, they shut off 8, I believe, last week I found out, and it's very specific by provider. At our healthcare system, we can't change a billing practice by provider. So for radiology, they turned off a vascular study 1. It still needs to go through the same review process because we're not sure if that provider would, they're looking at our system, so it's unique. So their review has been committed, they'll review in a year. That's a year of wasted time. And then we've been told it's a yearly review process, which again, we want to be proactive and bill correctly. But, when we're looking at 70% compliance, those are numbers that I just had of what is being approved. That's only on what they're responding to. It's taking more than 60 days for them to respond. So they've said basically it's kind of gold card. Like if you do well, you get this turned off. But to get to that do well point, someone said it here, we don't even know the standards we're being measured against and the time to do that. So, and I know Blue Cross is speaking, so I would also defer to them.
It seems funny that all of a sudden this comes up and all of a sudden these things get put in. Were you warned, were any folks warned of, hey, you got to code properly, you're doing it wrong, okay, we're going to implement this?
It was, I think the letters were sent in one of the material. It was one letter and then the policy. And that was statewide, like not.
And so your face-to-face never uncovered any, you guys aren't doing it right, so we're going to do, no.
We do have audits, so they have the right, if they find we're billing ED really high, they can come and do the medical record review. But no, nothing that precipitated this Cotiviti vendor coming in.
Thank you.
And so just to follow up on that, and I know Alyssa has a question. So prior to this cotivity going into place, audits were done to providers, and there could be a process where if they found something, there would be a discussion, and then, but now it's almost like that's on the back end, and it's immediately denied.
Immediately denied and records requested. So again, some payers will look and, they'll have flags in their system and they'll do an audit and they have the right. But yeah, it's immediate denied. Some are going through, and I'll be candid, we're not sure why. I have, we do have some modifier 25s and 50 or 59, is the focus of the hospital team I have been focusing with. They are going through. So not all are getting denied on the 59, but it's unclear exactly why. So, and to the point of billing, we are looking if we're coding correctly or not, and should we code otherwise, but we don't change codes, we write them off. We're doing the services, and we are looking and working with our counterparts at Blue Cross to learn, but there hasn't been like a significant action to simplay this.
And I apologize if this is your testimony.
Yep.
Do you have an estimate of financial impact?
So it is in progress because again, we've not only started. So overall since, and I just got the July last year, of when this one team, it's called an underpayments team. So the staffing I mentioned, the 200 doesn't count my contracting, another analytics team and underpayments. So that's just billers. Just at the medical center, and this is only for modifier 59 because this is a larger impact area. So I've pulled data. We've had 768 counts denied. We've sent individual fax of 1,282 individual medical record emails. And that recalls. We've gotten responses back of successful processing of 585 of those 1,282. We're still waiting for responses on the rest, or we've gotten flat out denials of 222. So you can still see we're waiting for 500 claims. These go up at least in, I will say at the medical center, 50-ish a week, but I have a feeling we're not capturing them all.
And so this is, and I just want to be clear, so when we talk about UVM Health Network, and this is happening at every hospital as well. So UVM Health Network, we are only talking in those numbers you gave us of UVM MC. We are not talking if I go to UVM for primary care, or if I'm going to Porter, or if I'm going to CVMC. And I have the Porter and CVMC numbers. We only started working those on this small team in September, so they're understated. But CVMC, 803 denied. We've faxed only at this point 353. We're still working back that 500. We've faxed 353. We've only gotten responses on 45 successfully.
And 59 modifier.
This is only the 59. So things we have had denials for the left-right laterality, primary diagnosis code. There's a transplant component. If you look into there's many others that impact the hospital. The 59, I'll say, is the highest dollar. So that's where I have really a red flag, because this gets to ultimately our budget that's approved. Mm-hmm. This is not what we budget. We don't budget for these cuts. So again, this is, I know colleagues at Rutland, we've talked with them, we have talked with other hospitals, but yes, these are just small examples. If you extrapolate them out, and it's in my testimony on the professional side, we have a whole different team that's a primary care specialist. Their denials for Blue Cross alone year over year have gone up 200%. And that's teams that have to work it. So there's almost 20 million in denials from Blue Cross right now across our system.
And so of the UVMMC numbers you gave us, for example, do you have the financial impact, not just the number of claims?
So what I don't have, I have how much we've recovered. I don't have the denominator of what that is, because my team candidly said we're trying to pull that in a concise manner because we still have some outstanding. They're very specific in what they say is outstanding, because so I can pull that, but it's just about 650,000 we've recovered just at the medical center. Again, I don't know the outstanding denominator to that because we were going through.
Okay. As you get information, please feel free to Alyssa and then Daisy.
So unlike some of the offices that UVM obviously employs certified coders.
Yes.
So theoretically, I'm assuming that if you're sending records on these, the claim denial is being looked at by a certified coder that says, this is totally appropriate. And I'm wondering, of the denials that you've received, if there's any appeal process in place for your certified coder to discuss with their certified coder to decide which certified coder is making the correct decision.
So that's where there's a lot. So claim edits are not seen as denials. It's that front end process. So if you get denied a claim, if I went and had plastic surgery, for example, often not seen as a covered benefit. So Blue Cross would deny it. So then if it was something that I needed that the doctor felt medically necessary, they would appeal it. And then there's second level appeals and could go to DFR. And there's a true policy there. Claim edits are in this gray area because it's not seen as a denial. It's that algorithm that's cutting it off at the beginning. So if it has gone back through the medical record getting submitted, we honestly haven't had the resources to completely appeal them yet and argue it should be appealed. So that is something we're talking about with Blue Cross. I don't want to say it's off the table and, they can speak to that. In theory, would have an appeal process, but that appeal process, so for example, they've denied that we should challenge appeal 222. We would have to follow that appeals process for each one, which is again, coder to coder on an individual basis.
And currently there's no process for that.
We haven't engaged in that, and I'll say, so there is an appeal process, we haven't pushed that.
Daisy? Oh, are you done?
Yeah.
Okay. Daisy?
I think I heard you say that there were, at this point in time, approximately 20 million in outstanding denied claims.
Of all Blue Cross, not just these edits. I want to be clear, like that's the scope, and that's across our whole health network. That's not, I don't have it specifically, I just pulled high level.
Can you articulate for us again what providers or types of providers that network includes?
So our network across the 6 hospitals includes the hospital services, primary care, specialties providers, radiology lab, medical equipment, and pharmacy claims are separate. So that does not include pharmacy that we have, unless it's in the like in infusion. So it's really the whole gamut of our services.
Are you good, Daisy? Yeah. Any other questions? Thank you.
Thank you very much.
I appreciate it.
Have a good day.
So I'm going to do something that I might regret, but I'm going to try it because we have some other providers in the room or some other associations. We have some time? I'm really looking at you and Jessa and Devin. Does anyone want to testify?
I'm Susan. Hey, everybody. For the record, I'm Susan Ritson with Health First. I'm the Executive Director of Independent Practice Association. I just want to emphasize this is a huge deal for our independent practices that are affected. Not all are affected, but the ones like Dr. Lynn's practice that are, it's just huge. It's taking a ton of time. They're sort of giving up because it's just so onerous. I'll also add that what makes this different, what makes Blue Cross different is that they're not paying. The other, payers will audit on the back end, but they'll pay. So it's that upfront denial or withholding of the payment that's particularly problematic. So those are the main things I wanted to emphasize. But this is a really big deal. Can't emphasize that enough.
So obviously you weren't expecting to testify. Do you mind taking questions?
Sure.
And if you're uncomfortable.
Yeah, no, that's fine.
Ready, that's fine. Do you have any data or even anecdotal data from the independents on one, having to hire more people and or having to say you're no longer taking Blue Cross Blue Shield?
I don't have formal data on that. I have what I've heard from practices is that, yes, they're spending a huge amount of time administratively. I know, Dr. Lynn's practice did hire some more. I'm thinking like ophthalmologists are really affected on this. And to this point, I don't believe that they've hired new staff, but their, existing staff in the docks are having to get in there and spend a lot of their time dealing with this. So I apologize.
No, that's
I don't
fine.
have a lot of.
And I want to be clear, this was
Yeah.
not expected.
Yeah.
So please don't worry about that. I had another question that went out of my head. Leslie?
Yeah, I don't know if you know this, or I'm wondering if this problem has led to practices not accepting new patients or having a delay of care way, much longer as a result of this problem.
I know there's definitely been talk amongst our practices to maybe not accept Blue Cross, but of course, that's a risk for them, being a major payer, but there has been that discussion. And I will just say anecdotally, with all of the payer just complexities, we are seeing more and more independent practice moving to a direct care practice. So they're not taking any insurance at all. They're just directly dealing with the patient, taking a membership fee. So we are definitely seeing an increase in that in our network, and that, things like this is just going to add to that, which, it may not be great.
If I could follow. So if that happens, then the patient can bill them their insurance directly? How does that work?
Pay for it.
They just.
Right, they pay a membership
They can
fee.
access it on their own if they have it.
Right,
Well,
yeah. So,
Yeah.
But, if you look at, the burnout that's happening in the provider community, like I had one of our physicians say, well, I decided to move to direct primary care because, playing in the system as it is just being part of the problem. And I'm going to burn out and say, forget it. I'm not going to see any patients or do this, which at least I can see patients. That's why I went to medical school. So they're making that hard choice because of these sorts of things. I mean, just imagine if, for you to get paid, you had different rules for each committee you worked in, and you had to, just go through figure out all these rules just to get paid for a service that you're legitimately providing. It's ridiculous.
I just wondered if you'd anecdotally heard of any practices discussing just having people come back twice, come back again for the.
Yes, that's definitely happening. They're having those discussions.
For everybody else.
Right.
because-
Yeah, but they've had to. They can't absorb that extra cost. Of course, they're asking the patients for their permission, and most of them are gracious, but it's, not ideal for sure.
Not to interrupt.
Yeah.
On that issue, the 25 modifier, I think that's what you're talking about as far as them coming back. Has that specific issue been addressed with Blue Cross?
Yes.
What is the reply?
We will hear from
Oh,
the
you got
press.
that? Okay, all right.
Yes, I know what.
All right.
Answer for Blue Cross Blue Shield.
Yeah.
I mean, you can answer to your
Yeah.
perspective of it, but.
Yeah, we've talked with them about it, yeah. The practices have talked with them about it at length, yeah.
And you're still dealing with the issue.
Yes. They've corrected it in some cases, which is also part of the problem. We've been saying these are being denied, we can't figure out why. Then they look at it and then they're approving them, which, it tells you that for months and months and months, practices have been having to deal with all these administrative issues when the edit was not necessary in the first place. And it's just crazy, crazy making, yeah.
Great, thank you. I appreciate you.
Yeah.
So we will hear from Blue Cross Blue Shield and DFR. So the meeting that was had in November, I think that was the one you attended, and DFR, Sebastian has been involved in this process throughout the summer and fall. So he will talk to us about some of the conversations and things that have been happening. So we'll hear much more information this afternoon.
And that meeting was November 23rd?
November of 23. Yes, I'm sure there were other,
Right, but
there may or may not have been, but I think, yes. Yeah, so this started in January of 22.
23.
23, I still think we're in 23.
Yeah.
January of 23, and then through the summer, there were a lot of conversations. Sebastian got involved. There was a meeting of everyone in November.
Have a big family meeting that.
Big family. We all know how those family meetings go sometimes. Any questions, comments?
Just worried that insurance companies are listening to this and they're going to come up with a new workaround for the workaround, and then there'll have to be another workaround.
It's a lot of, it's what healthcare does, right, Molly? And I apologize. I don't remember if I said this in the beginning. I think I did, but we are introducing a bill, which has not been introduced yet. So we will come back to this because there is language in that bill. But I wanted to get this conversation started because it is obviously so important to our healthcare system.
Can we talk to, again, offline about seeing if there's a way to include pharmacy in this, seeing as how they are like actively deciding not to use Blue Cross Blue Shield for durable medical equipment and stuff like that because of this issue?
Let's talk offline.
Okay.
Great. Offline between you and me, not the whole committee, because we don't talk policy offline. So make that clear. Okay, so we are back at 1:15. I appreciate everyone coming and your input. Please feel free to send us any additional data that you want us to look at.